Good evening, and I'd like to thank Yazan for the invitation to share with you our early experience of targeted axillary dissection using Magseeds in the axillary nodes for breast cancer on behalf of the breast unit at the Royal Marsden. I have no disclosures, but the Marsden does host surgeons and radiologists who wish to see and learn the process, and I certainly extend the invitation to any of you who'd like to come and visit us. The Magseed is a tiny stainless steel pellet with a helical texture, just 1 millimeter in diameter and 5 millimeters long. And its paramagnetic qualities in conjunction with the Sentimag probe means that a signal is generated that is read out here on the display, dependent on the proximity of the probe tip to the Magseed device. The closer it is, the higher the signal. The introducer itself is just an 18-gauge needle, which our radiologists use under ultrasound guidance to deploy the Magseed accurately within the lymph node. And assisting this is a small wax bolus that stops premature dislodgement of the actual Magseed. Now, we know that there are many alternatives to Magseed devices, such as I-125 iodine seeds, which are radioactive. Wires, of course, a very traditional method for both breast and axillary localization, colloidal carbon tracking, RF tagging, and other methods as well. What are the potential benefits here? Well, from a patient perspective, the localization of the lymph node can be uncoupled from the day of surgery. There are no wires sticking out, but furthermore, with Magseed, there's no radioactivity. From a radiology perspective, it's very easy to insert, and it can be done at a convenient time, not during a busy one-stop clinic. From a surgeon perspective, transcutaneous identification, particularly in the axilla, is extremely simple. The downsides, of course, are that due to its paramagnetic qualities, there is artifact causing a signal void around the Magseed for about 3 to 4 centimeters when certain MRI sequences are used. And despite this, however, it is safe to have a Magseed in place if the patient does need an MRI, and it's been tested up to 3 Tesla. Surgeons need to use non-ferrous retractors when performing the procedures, as this interferes with the magnetic signal. And of course, cost may be an issue, but I will show that in the axillary context, it's probably even more cost-effective than for breast localization. The background in the Marsden, we first started using Magseeds in the breast, of course, and my colleague, Miss Rusby, led this study of 100 wires versus 100 Magseed cases, our first cases at the Marsden, and she showed clearly that there was a workflow improvement and more efficiency in theatre, although this wasn't statistically significant. But what was highlighted was a lower specimen weight in the wide local excision cases. And I draw your attention to the article published by Katerina Mika et al. On this. Well, to set the scene for the axilla then, which I'm going to completely focus on now, we can see the lymph node on ultrasound as a hypoechoic structure. This is about 14 by 4 millimeters. And you can see the needle deploying the Magseed, the latter which you can see easily in the node as an echogenic line in the lower panels. You can see the radiologist here demonstrating the ease of use of the introducer. There's a small separator that's removed, and then the needle can be advanced to a certain point. And as I mentioned, there's a small wax bolus that stops the pellet dropping out of the needle. This means that it can be used with a single hand technique, while the other hand uses the probe to accurately locate the node with this procedure. And here is a video showing the procedure in real time. And on both panels, you can see the needle approaching from the left of the lymph node. On the left side, we have a large de novo abnormal node before chemotherapy. On the right side, the node has been responded to chemotherapy and is much tinier and fibrosed and is therefore more challenging to insert, and of course is a smaller target than that seen on the left. And you can see just now the seed deployed within the lymph node. What about the context? Well, firstly, as I mentioned, we started off and we have now done over 500 breast localizations, but our experience in the axilla is relatively early, with 83 attempts at axillary Magseed insertion. And of these, most were successful, and I'll go through the figures in detail. And there are three scenarios I'd like to discuss. Firstly, is targeted axillary dissection after neoadjuvant chemotherapy, and that's the classical one that most of us would associate with the use of Magseed in the axilla. We have 45 patients who were planned for neoadjuvant chemotherapy with node involvement at the outset. And our standard of care is to perform an axillary ultrasound at diagnosis, then an FNA or core biopsy of the abnormal node on ultrasound, and insertion initially of an O12 marker prior to neoadjuvant chemotherapy. When we started, this was our practice, and this is the tiny O12 marker, which is about 2 millimeters in diameter. It's very stable within the lymph node, but there were difficulties. The challenges were that, firstly, for the radiologist, if the node had responded very well and was difficult to visualize on the ultrasound at the end of chemotherapy, the O12 was difficult to see. And therefore, not all the Magseeds could be inserted. Furthermore, we struggled as surgeons, not to mention struggled training our trainees, to locate the nodes with these O12s because they were very difficult to find in some cases. We had to X-ray the nodes, which caused delays. And I must say we caused excessive trauma to the axilla in trying to locate them. Well, we then transitioned, firstly, when we started using Magseeds in the axilla, to inserting the Magseed at the end of chemotherapy with the O12 in place. Now, this is 32 cases we did this for. They had the prior O12 as mentioned, and unfortunately in 3 cases, the O12 marker could not be seen as the node had normalized completely, and so from an intention to treat point of view, these cases were abandoned. The Magseed was inserted but not found in one of the lymph nodes, where it was found in the fascia and later on the surgical drape. Aside from those 4 cases, we were successful in locating all the other nodes, but the radiologists did report that it was much more challenging to insert at the end of chemotherapy. And of course, these cases were selected for their good response, otherwise we wouldn't have indicated to do a targeted axillary dissection approach in the first place. The median age of these patients was 52 years, with the usual range, and notably, 3/4 of our patients were either HER2 positive or triple negative in receptor status. Here is an example of a lymph node, just 4 millimeters, but clearly abnormal. And you can see how difficult it can be, although visible in this image, to see the O12 marker. It's the small echogenic ring. It's quite difficult to see. This is only a few millimeters in diameter. Again, here is the Magseed, and again, without the hypoechoic large node, it's very difficult also to see that on occasion. Well, the next step in our transition as we progressed through this process was to insert the Magseed at the beginning of neoadjuvant chemotherapy and abandon the O12 marker altogether. We had 13 patients in whom we've now inserted the Magseed initially. It's certainly easy for the radiologist to perform this. And we did, however, note that there may be possible interference with patients having breast MRI. But at the Marsden, in fact, our default position is to use ultrasound to monitor treatment response both in the breast and the axilla, in particularly in the axilla. And MR use is quite exceptional. If we do have a patient in whom MR is required, then, of course, patients in whom the primary was within 3 centimeters of the axilla were excluded from having a Magseed at the outset. And so far, all nodes have been successfully found and removed in 11 cases out of the 13. And this is a possible pathway to the ATNEC trial, a UK-led trial of neoadjuvant chemotherapy, and when there's a complete pathological response to the treatment in the axilla, then patients can be randomized to no axillary treatment or else radiotherapy or surgery to the axilla. Well, here's a patient example, a recent diagnosis. We can see the axillary node here on the PET-CT, very FDG avid. Here's the breast primary, and again the node shown in the axial section. This shows a Magseed placed at the outset in the breast primary, but also in the rather large and easily visible hypoechoic but very abnormal lymph node. Well, what were our results? In the 41 cases that were successful out of 44, the HER2 positive cases had an 80% PCR rate in the axilla, such that only 4 out of 20 nodes had residual disease, but all the other non-sentinel nodes were clear. In triple negative setting, in triple negative patients, the PCR rate was 73%, and only 3 out of 11 had residual disease, but all these patients had disease beyond the index or sentinel nodes during our axillary clearance. And the same with our luminal B patients, again quite a high PCR rate in the axilla, but when it was positive, we always cleared and we found residual disease. But this highlights the fact that one can conserve the axilla in the majority of patients in this context. The PCR rate may be thought to be abnormally high, but of course we are biased here because we're selecting insertion of Magseed for those cases who have responded well. And this is a video to illustrate a procedure done by my colleague Ms. Krupa. First we zero the probe to calibrate it, and then you can see the probe showing a very high signal in the axilla. And then, interestingly, in this case, the sentinel node showed radioisotope uptake and was also blue. But in fact, it's the node underneath that you can see the magnetic signal actually emanates from. And it's the non-blue, non-isotope positive node. And you can see the node is not pigmented. And in fact, there was no uptake of isotope in this node. And in fact, this node was the only positive one, i.e. the true index node with the Magseed within it. So how do we simplify the workflow as well as the patient journey in the context of neoadjuvant chemotherapy? Well, in this cartoon, I want to take you through our process prior to using Magseed and show how we transitioned to simplify the process. We performed the diagnostic axillary ultrasound, as I mentioned, proved that the node was involved pathologically. This was obviously upsetting for the patient. The radiologist can be seen above the patient there with a diagnosis made. And then, of course, the patient had to return prior to chemotherapy to mark the index node, and as I mentioned as we started, with an O12 marker. This caused more concern for the patient with a second interventional procedure prior to chemotherapy. And of course, the radiologist found this challenging but satisfying. Chemotherapy was then undertaken with axillary ultrasound to monitor response in the axilla. And then the pre-op consultation was interesting because patients were always shocked that we then had to insert yet another marker. But doctor, I've already got a marker in. Well, we'd explain, of course, that the first marker was not reliably identifiable during surgery, and therefore we advised the insertion of the Magseed node at this stage to remark the index node. And of course, this was another procedure for the patient who then had even more concerns about potentially getting COVID-19 due to further exposure to the hospital. And then, of course, at surgery, we'd perform dual localization, identify the index node using the Magseed and Sentimag probe, remove it, and then remove the non-index sentinel nodes, and then test all. And we are lucky enough to be able to do this intraoperatively using OSNA. But of course, sometimes a second procedure will be required to manage the axilla in appropriate fashion. Now, how did we then simplify this? Well, as I mentioned, we transitioned to omit insertion of the O12 marker, inserting the Magseed after the diagnostic procedure, once we'd proven that the nodal involvement existed, and to place it in the index node prior to chemotherapy. And this made the patient a little less unhappy. But importantly, it meant that we could skip the final insertion, and this certainly obviated the need for a further marker placement prior to surgery. So saved a very important and crucial step in the process. And I think you can already begin to appreciate how this then becomes very cost effective if we take the savings into account from not having to put an initial marker in. And this is our current situation and management flow as it exists today. And one wonders for the future, and perhaps slightly controversially, but perhaps in selected patients, we can move this even into a one-step procedure where during the diagnostic biopsy, for example, with the U5 radiologically very definite malignant features of the node, to insert the Magseed already in the largest node at that point, to mark the index node in the single procedure. And I think the radiologists would think that this is very cool indeed, saving yet, of course, another procedure for the patient. So I'm now going to talk about the scenario of what we call primary TAD at the Marsden, where we've done 30 cases. And this is in the context of patients having primary surgery. So what do I mean by this? Well, there's a unit approach to try and de-escalate axillary surgery. And of course, the problem nowadays that we face is that radiology and axillary ultrasound in particular are very sensitive. They will pick up very tiny solitary nodes, which they will designate as anywhere from U3 equivocal to U5 definitely malignant, and of course biopsy prove these. But using Z11 or our Posnock criteria, which is another UK trial, similar to Z11 in some ways, whereby T1 or T2 primary cancers who are deemed to undergo primary surgery, i.e. usually they're ER positive, HER2 negative, thought not to respond to neoadjuvant chemotherapy, with 1 to 2 positive nodes could be spared axillary clearance by these criteria. And they may be micro or macroscopic nodes, of course. Now, the options in this situation are that we do no axillary treatment beyond the removal of these 1 or 2 lymph nodes, or that we offer patients axillary radiotherapy or surgery if they so wish, or we can enroll them and randomize them within the Posnock trial in the UK. Now, here is a patient having a Magseed inserted in the primary context, quite a small node, and you can see the resistance there until the needle penetrates the actual capsule of the node with the Magseed deployed. But this is what we've been doing in patients who undergo primary surgery and have just 1 abnormal node visible, possibly up to 2. And you can see again the characteristic appearance of the Magseed in the node. We have 30 patients, and their early results, median age 58 years. And you can see in this population now, 80% of our patients are ER positive and HER2 negative. The O12 was inserted in 6 of these patients initially, as the treatment plan was a little uncertain before we got the actual diagnosis and knew the phenotype, the receptor phenotype for the patient. 3 out of 30 patients, in 10%, the marked node was actually not malignant. Now, you could say that this was a wasted procedure, but in fact the node did look abnormal, and in many cases where we have a U3 or U4 node, of course, we will find that the node is involved. But in this series, 3 were not. In a further 16 out of 30 patients, they had only 1 or no further nodal involvement apart from the Magseed targeted node, and were therefore able to be spared axillary lymph node dissection. In a further 11 patients, we tested at least 2 further nodes and found that the patients had more than 2 nodes involved, and therefore they did undergo axillary dissection. And this shows that we can spare approximately half the patients in this context from clearance despite a positive node. Well, the final scenario that I'll just touch upon now is a potpourri of other indications, including stage 4 disease where there's nodal positivity and maybe activity on a PET scan or ultrasound, where we'll mark the node, and then in the case where there's progression, use the Magseed to target removal of that node where we don't want to cause a significant trauma by axillary lymph node dissection. Similarly, in an axillary recurrence where there's a single node recurrence after previous clearance and or radiotherapy, we will use Magseed to target the node where it's impalpable, and this has been incredibly helpful and really cut down our operating time. There are 2 cases of hematological malignancy where this has also been useful as we provide this service at the Marsden. Finally, I'd like to acknowledge my surgical colleagues, in particular Ms. Rusby, Ms. Krupa, and Katerina Mika. And last but certainly not least, my radiology colleagues. And I really want to highlight, and I've said this probably and emphasized this during the last 20 minutes or so, that without good radiological localization of any marker within the axilla, and in particular the Magseed, really we have no hope as surgeons of doing a good operation. So we're completely dependent on our radiologists. And I'd like to just offer a message to everyone that to get together with your radiologists, develop a good relationship with them, see how they actually do the procedure, and get their feedback when it comes to axillary localization. And remember, if it's easier for them, it'll make our lives as surgeons much, much easier, and of course, minimize trauma to the patients that we treat. Thank you.